So, gosh, you may be saying, wow, doc, that sounds pretty bad. What can we do about it? Well, let me say this. For those of us who were involved in any way in healthcare during the beginning and throughout the COVID-19 pandemic, this time is going to certainly be remembered as the most challenging, gut wrenching, and anxiety provoking time of our career. I mean, for many of us, especially those of us who are a little long in the tooth, as they say, we essentially risked our lives and maybe even the welfare of our families to do what we took an oath to do. And we did that in many cases with limited tools, limited resources, because no one saw this coming. But in the process, whether we realized it or not, the art of medicine was reborn. What did we do? Well, first of all, we listened to our patients. There's a novel concept. Then, after we heard their story, we simply utilized the knowledge we had gained from our training and experience to help mitigate risk and alleviate pain and suffering for our patients. And for most of us, we learned more about acute medicine and more about ourselves than we had since our training. So with this in mind, let's talk about some things that we might be able to do for patients with long COVID. Problem one was persistent chronic inflammation. Well, we know a little something about managing patients with chronic inflammation. All of us have some level of experience with autoimmune illness. And in fact, there have, in these preliminary days, been a couple of studies suggesting that there is significant benefit and or resolution of symptoms in patients with long COVID with tapering doses of corticosteroids. Other immune modulators have been suggested as well. So we know that the underlying problem is chronic inflammation. Immune modulation seems to be one way where we could make a difference in the symptoms of our patients without coloring too far outside the lines. What about oxidative stress? Well, let's think about antioxidants. Okay, things like vitamin C or N-acetylcysteine, the immediate precursor to glutathione, a very powerful antioxidant in the body. Vitamin E, melatonin. There's actually been one study in long COVID that talks about the benefits of the antioxidant effects of melatonin in patients with long COVID. And then bioflavonoids like quercetin or luteolin have been suggested as well to modulate immunity and stabilize mast cells, which are part of the overwhelming immune response. I think we all can agree, based on what we know about oxidative stress, that if we know our patients have oxidative stress, there's no downside to reducing oxidative stress in our patients. So again, I think there's an opportunity here perhaps. I'm not giving a protocol for treatment. I'm just saying there are some things that make sense that have been talked about and suggested in the literature that might be beneficial. What about mitochondrial dysfunction? Well, not a lot of us do a lot to treat mitochondrial dysfunction, but the best thing we can do for mitochondrial dysfunction in these patients is treat their oxidative stress or help them figure out a way to minimize their oxidative stress. There are supplements that are available that support mitochondrial function. That may be another option at some point down the road. But certainly treating oxidative stress or minimizing oxidative stress is the place to start for mitochondrial dysfunction. So look, I hear you. We need randomized controlled trials. Where are the randomized controlled trials? They're coming, but they won't be here tomorrow. And our patients are going to need them interventions tomorrow. So if you review the literature on long COVID, many of these that have made proclamations about it being the new next healthcare crisis and others suggest that the time to act is now. Much like we did during the COVID pandemic. We may have to assimilate and contemplate and extrapolate and maybe repurpose to alleviate pain and suffering in our patients. We may have no choice but to practice the art of medicine. Is there urgency? I strongly believe there is. Prolonged severe inflammation and overwhelming oxidative stress are not only unhealthy but risky. Children, again, should not be walking around with high levels of oxidative stress and inflammation. Are there going to be consequences to that downstream? I and many others who have commented on this in the literature believe there will be. See, I believe there will be a post-long COVID phase where this untethered inflammation and overwhelming oxidative stress, which is not typical, paves the way for more autoimmune illness down the road, increased diagnoses of autoimmune illnesses, and maybe even malignancies. And this will not be just adults. This could very well be children as well. So I do believe there's urgency to minimize oxidative stress and minimize inflammation in some way to assist these patients and protect them long term. So I said we can believe what we see or see what we believe. I believe we need to be seeing long COVID. I believe we need to be hearing our patients and listening to our patients because patients are suffering, and it's not just adults. We have to recognize long COVID for what it is, which is a medical condition, a post-infectious syndrome that is medical, even if it has neuropsychiatric symptoms. And that we need to acknowledge that we are all genetically, or at least epigenetically, different. And so with this post-infectious syndrome, it is unlikely that there's going to be a one-size-fits-all solution. We are going to have to practice the art of medicine if we're going to help our patients. So I hope this has been helpful to kind of explain what long COVID is, to make an argument for the fact that it is, I believe, incredibly important and something that we do not need to ignore due to long-term risks. I am excited about more studies to come in the future. The NIH has put $1.15 billion out there to study long COVID, and so I think those randomized controlled trials are coming. But I do believe that we have to act now and try to help our patients in a safe but effective way in order to protect them long term. And I think we need to have more dialogue about this among physicians as we are all doing the best we can to do what we took an oath to do. I want to thank you for your time today. My name is Claude Ashley, and I'm at Innovative Healthcare in Dothan, Alabama. Thank you.